Hello, my name is Malin Sund, editor assistant for the BGS. Today I will interview Professor Peer Christensen from Aarhus University Hospital in Denmark. The topic of today is intrathoracic goitre. Professor Christensen is the 2011 P.O. Granberg Lecturer of the Swedish Society of Endocrine Surgeons. Professor Christensen, the incidence of intrathoracic goitre varies in the literature due to many definitions. Which definition do you prefer and why?
Well, I think there is at least two definitions which should be used in connection with the intrathoracic goitre. The one is 50% or more of the thyroid behind or below the thoracic inlet. That's a good definition. And the other one is a level of thyroid in the mediastinum lower than the tracheal carina.
In the surgical management of an intrathoracic goitre, sometimes an extracervical approach is needed. Is there any way to predict preoperatively when this approach would be needed?
You can't predict it for sure before the operation, but there are some indications pointing at the need for an extracervical approach. For instance, if it's subcarinal, then there is up to 25% risk of the need for a sternotomy or extracervical approach to that. In the case of 50% or more of the thyroid lobe below the thoracic inlet, there is a risk about 8–10% for the need for a sternotomy.
You mentioned something in your lecture about the value of contrast-enhanced CT. Could you mention something about this?
Well, there is a group from Turkey who has studied the density of the thyroid lobe on CT scans, contrast-enhanced CT scans. And they defined a harder density of the thyroid lobe in about 1/3 of their patients. And in these cases, there was a much higher risk of the need for a sternotomy during the operations.
That's quite interesting. So when this extracervical approach is used, what are the most common complications arising when compared to the cervical approach only?
Well, I think, of course, there is complications specific attached to the sternotomy. There's a risk of infection in the sternum, for instance, a very serious complication. There is complications like pneumonia, atelectasis, and so on. But concerning the specific complications, laryngeal nerve paralysis and hypoparathyroidism, I'm not quite sure that the intrathoracic, the extracervical approach increases the risk. On the contrary, there is some data indicating that after sternotomy, the risk of laryngeal nerve paralysis is at least not increased. Maybe it's a little lower.
So in selected cases, one should not hesitate to use this method?
No, that should be the message. It's better to perform a sternotomy and open the wound instead of trying to retract a thyroid to the neck where there is no space for that.
Okay, thank you very much for this interview and for your very interesting lecture today.
Thank you.